Hey everyone, good evening. This is Dr. Sullivan back with you for another Eye Care for Your Brain. We meet here weekly to exchange ideas and thoughts and communicate about all things related to brain health. Last week I was with you and we were talking about the so-called behavior symptoms in dementia, specifically Alzheimer's disease. And I went through kind of like 5 golden rules to try to help caregivers, people who love people who are struggling with these behavior symptoms, just kind of cope a little bit better, maybe feel a little bit validated, get some ideas about what might work. So what I want to do tonight is finish up on those and go from numbers 5 to 10. These are from the Family Caregiver Alliance website. They're a really wonderful group who works really hard to advocate on behalf of caregivers. So when we talk about these behavior symptoms, and I always am going to put them in quotes because many times the problem is on our end. We have a problem with the behaviors. Many times it's because these individuals are bored, because these individuals cannot communicate properly, maybe because they're in pain. I'm hesitant to want to call them behavior issues when really it is more of just another aspect of having dementia. But if you are looking in the literature, the scientific literature, these symptoms run the gamut from things like apathy, just kind of not being motivated to want to do the things that the person usually did, all the way up to things like visual hallucinations, delusions, feeling like people are maybe coming into their house, taking their pocketbook, these kind of things. They can come very early on in the dementia process. We talked about in the case of Alzheimer's disease that many people, their very first symptom, even before short-term memory loss, is a degree of apathy, a degree of poor initiation, not really seeming as invested, as interested, having as wide range of emotions as maybe they did before. It's only when we go through some time and we look back, hindsight being 20/20, that we can see, that's when it really started. Whereas maybe at the time we thought, oh, maybe it's retirement, maybe it's a little bit of depression, maybe it's just getting older. But when we look back and we really try to put the whole experience of Alzheimer's into one understanding, we can see, that actually was a symptom that was happening at the very beginning. These behavior issues can come, they can go, they can always be there. It is really difficult to make any generalizations, just like it is about all things related to the brain, because every brain is different on the front end and every single brain is unique and different as it goes through dementia. So we don't want to approach this medical disorder with a cookie cutter. We want to acknowledge the uniqueness and the humanity that each person brings to dementia. The key in figuring out what we're going to do about these so-called behavior symptoms is figuring out the level of distress. So what I mean by that is, how much is it bothering the person and how much is it bothering the caregiver? So is it getting in the way of function? Is it getting in the way of quality of life? So some of the things we need to do in order to answer those questions and figure out, okay, if the answer is yes, and we can't get the person in the shower because they're overwhelmed by anxiety, because we can't get the person to take their medications because they're afraid there's poison in the medication. The caregiver isn't getting nearly enough sleep at night because the person is up wandering in the night. This is the point where we have to decide we're going to do something about it, right? Sometimes there's behavior symptoms, but there's no distress. The person may think someone is coming into the house, but they're looking forward to it. They may set out food for children that are coming to the back door after school to be fed because they're hungry, and it's something they actually look forward to doing. So it really matters how much it bothers the person or how much it bothers those of us on the other side. So the first thing we have to do is we want to make sure that we actually understand the specific subtype of dementia that the person has. If you've been following me, I hope that one of the key things that I've empowered you with is that a diagnosis of dementia is not sufficient. Dementia is the umbrella, broad term. There are many different causes of dementia. There's many subtypes of dementia. And the subtypes matter. They matter for many reasons, but as it relates to this conversation, it matters because it tells us what behavior symptoms are more likely to go along with the diagnosis. So for example, with the frontotemporal dementias, so these are degenerative dementias that affect the frontal and the temporal lobes in the brain. This is where we see a lot more of the kind of big and bright behavior symptoms. So things like being very impulsive or disinhibited, you know, all of a sudden cussing when maybe you didn't before, kind of being in other people's space, going and eating a lot of things before becoming very oral. This is something you're much more likely to see in FTD, frontotemporal dementia, as opposed to something like Parkinson's disease. Whereas in dementia in Parkinson's or Lewy body dementia, we are much more likely to see these visual hallucinations. In fact, a lot of times they tend to be very similar. They tend to be of little things in the environment. We call them Lilliputians, little animals running around, little kids looking out of the window and seeing something little off in the distance, a little type of scarecrow, for example. In Alzheimer's disease, we're much more likely to get delusions. Like I said before, someone's been in my purse, someone's been coming into my home. So the first thing we want to do is make sure we're getting the subtype right, because then we have a little bit more of a grid or a guideline to say, you know, this is a common behavior symptom that goes along with this dementia diagnosis. The second thing is we always want to rule out that there's not a delirium happening. Delirium is when there is a sudden worsening of cognitive symptoms in dementia, behavior symptoms of dementia, and this is when we need to investigate that to make sure there's not an underlying reversible medical condition that's making it worse. The most common cause for a delirium on top of a dementia is a urinary tract infection. This is pretty easy to go get a urine sample, bring it to the primary care doctor, and make sure that we're doing what we need to do to just simply rule in or out a urinary tract infection. Also, sometimes just being constipated when you have dementia is something that can all of a sudden create a metabolic situation where the confusion seems worse, the person's behavior symptoms get worse. So the key there is if it seems like all of a sudden something changed, please be an advocate for this person and go to primary care and try your hardest to get them to do an evaluation for reversible causes of exacerbating dementia. The next one is we have to try to categorize these behaviors. They don't just come out of nowhere and make no sense. It's our job to figure out the cause, what exactly the behavior is, how to best describe it, and what exactly happens after. So this is where we talked last time about doing an ABC chart, which is antecedent, what happens right before, behavior, what exactly is happening, and C is consequence. So if you go back to my last Facebook Live, you'll be able to learn a little bit more about that. That is very helpful for giving it to the medical doctor to be able to kind of see the rhyme or reason, whatever the patterns are. So remember last time we talked about that the first thing we want to do is approach these behaviors with a kind of a curious attitude, really putting on our detective cap, being an investigator and figuring out what exactly is going on here. We then want to try to validate what is the underlying emotion here. Is it fear? Is it anxiety? Is it loneliness? Is it boredom? Is it pain? And then we want to try to fill that need emotionally and then distract. Part of many dementias is something called perseveration, where we can't let it go over and over and over. For some of us with advancing dementia, when we start to lose the cognitive thread of why we're having the same thought or feeling over and over again, it's more the emotion that sticks with us. So we get anxious about something else and we just can't break that anxiety loop. And so this is where we have to change environments, change the way we're talking to the person, introduce something through any other sense, touching, smelling, hearing, eating, just to kind of break the cycle. So this is where I want us to think about things that are personal to the person. So what was this person's job before? What were their hobbies, their interests? That's usually the hook to break the cycle of the behavior symptoms. So I've had many patients be kind of going over and over again something in their mind that, you know, when am I going to go home? When is my daughter coming for me? And let's say when they were able to work, they were a house cleaner. We go around and we find a broom and we say, hey, I need you to come over here, Mary, and I want you to help me get this kitchen in order because, you know, the boss is going to be coming soon and we got to make sure we're doing a good job. You'd be amazed at how that person kicks immediately into another mode and all of a sudden now is involved with doing this task of cleaning the kitchen. So try to use the person's past for your benefit. You really want to try to incorporate that in the distractions as much as possible. It's also amazing how distractingly powerful music can be, and also the sense of smell and touch. So getting some kind of a blanket, something with texture for the person to touch, putting a nice smell in the air, working on some type of cooking thing, so you can, the smell of an apple pie. These things are powerful brain distractions. So now what I want to do is get back to this top 10 list of these kind of just golden rules to help caregivers think a little bit differently about behavior symptoms. We did 1 through 4 last time, and I think maybe we did 1 through 5, and now we're going to do 6 through 10. So number 6 is one of my favorites, which is that oftentimes medical providers, doctors, are going to need to be educated by you. One of the things that I'm so grateful for in my career is that I did not come to this area of older adults and the brain and dementia just through book learning, just through formal education, that I was a caregiver and I have lived in homes with people who've had dementia for many years, and I feel like it makes me a much more sensitive, understanding type of doctor, because I think all too often doctors forget about the 23.5 other hours of your life before you have that 15 or 30 minutes directly in front of them. It is your job in this day and age of medicine to tell the doctor what's going on at home. And because your time is so limited with them, what I want you to do is start to keep lists and summaries and really try to get stuff sorted out as best you can before you get into that appointment. And then in the session, respectfully advocate that you need to know more about these issues. You need to know what their advice is on how you can try to help that person, comfort them, and get some quality of life for yourself. Number 7 is that you cannot do it all. I think this one is also really important. Sometimes people will say, I know when I'll need help. I know I'll know when I need someone in the house. But what I worry about with that line of thinking is that we're waiting until an absolute desperate situation has happened. I want you to try to think more about accepting help, even on the front end. Even if you feel like there's 20% of you that's overwhelmed right now, you will be able to be a better caregiver, a better spouse, a better friend if you are not even that 20% overextended or exhausted. So have a list of things that when people ask you, hey, what can I do to help? Picking up stamps. I need a prescription. In my part of the country, pine straw and pine cones pile up really quickly outside. I need to do this errand. If you always have a list of things, then when people ask you, you won't kind of be stuck and scrambling to try to find something. This also helps people know that when they ask you, you're going to take them up on it. And I find that this actually helps sort out the people who just kind of say it, and the people who can actually show up for you with reliability and that you can really count on. Because these people know if they ask, then you're going to say, actually, yeah, I could really use a meal to be brought over on Saturday. There are people that genuinely do want to help you, and we also know there's people out there who it's just kind of lip service. So instead of wasting your energy on the people that can't really show up for you, I've found that this is a really effective way to figure out who's actually going to be there. I'm also going to do a talk in the near future about making sure you're using all the community resources, specifically for respite. There's been a lot of changes that have been happening in the world of palliative care that I want to make sure you all know about. So hospice is kind of at the top of that. And hospice is an area that is fighting through some stereotypes. They're really not there just to help in the last few days or weeks of life. We can talk more about that another day, but underneath hospice is palliative care, which is for anyone who has a life-limiting diagnosis, which is what dementia is. So in my area, palliative care offers folks a week of respite for every 60 days that they are caregiving. It is a service that is supported by Medicare. And so I want to make sure you all know about that, because that's one of those breaks that's available to you. And it's amazing with just a few days of not having to constantly put out service to someone else, how much that can restore you. Number 8 is that it is easy to both overestimate and underestimate what your person can do sometimes. This is one of the most maddening things about dementia, is some days the person's capable of something and other days they're not. It makes it so it's very hard to get into a groove with caregiving, because sometimes you feel like you're overdoing it for the person, and other days you might worry that you're not helping them enough. This is a constant balancing act. You're constantly juggling the shift that happens in care needs from day to day. And so unfortunately, when you're looking for predictability in your life, caregiving is not one of those times you're going to really be able to get it. Number 9 is working on being more direct with what you need the person to do, as opposed to asking. This is one of those shifts I talked about last time, where when you're in a marriage, for example, you're very much used to being a team and a partnership and making decisions together. When you become a caregiver on top of being in a relationship, one of the key shifts that happens is that you have to be more directive. You do become a little bit more of the boss. We always want to respectfully include the person as much as they can participate in decision making, but the truth is, to make the day flow well, we also have to work on closing our questions and a little bit more telling and less asking. So for example, one of the issues they put on this website is, as opposed to what would you like for dinner, which could go any which way, we are going to eat dinner now. So it's a little bit more like, come on, we're doing, and a little bit less of what would you prefer to do, right? There's ways to incorporate choice even within telling someone what to do, which I think is always important, but not so much the big things. We want to make the choices a little bit smaller and less meaningful. So instead of, do you want salmon or grilled cheese, which would potentially take you on 2 totally different ways of preparing dinner, you can say, would you like salt or pepper, right? Things that aren't necessarily going to derail the caregiver's entire afternoon. And number 10, this is the recommendation from the Family Caregiver Alliance, is that it's perfectly normal to question if sometimes the person is actually exaggerating their impairments or their deficits. This again is because dementia is not static. There can be moments of total and complete clearness and lucidity, and there can be other times where the person is not able to help themselves at all. This is all part of dementia. This might seem to the non-experienced person that, hey, are they kind of like faking it? Many people who come to see me for their initial evaluation of dementia, the spouses will take me aside and say, honestly, I really don't know. Sometimes he seems like he knows exactly what I'm talking about, and other times he just acts like he almost doesn't even know what I'm saying. That's part of the testing experience and neuropsychological assessment, is we can figure out if there's some degree of exaggeration, but for many people it winds up being the dementia. That is part of it. Again, that's what's so challenging about it. It's really that there's never 2 days that are exactly the same, especially within certain subtypes. That's where understanding the Lewy body dementia really comes in very handy, because that specifically has fluctuations in mental status that really characterize that kind of dementia. And so as we wrap up, I really want us to think about why talking about the behavior symptoms is so important, is because if we don't talk about them, they are happening, right? If we don't talk about them, do you know how people are typically treated for these symptoms? It's chemical restraints, right? We think about things like physical restraints, like if you're out of control physically, people might have to get tied down. But we often forget that medicating people is really a form of chemical restraint. And I am not anti-medication. I'm also not pro medication. There are times when it is appropriate, but anyone who works in the aging field, I think, will tell you that it is frequently overused, and when it is used, it's frequently overdosed. And so one of the reasons I want to talk about this is because we have to have as our first line of intervention non-medication approaches, right? This is where we need to really bring the power of music therapy in. I was saying aromatherapy before. Investigate, validate, distract. We have to train people who are charged with the responsibility of people who have brain health challenges with knowing what to do when there's these so-called problem behaviors. There are way too many people in the medical field working to take care of people with traumatic brain injury, stroke, dementia, who have absolutely zero training in the brain, zero training in what to do if someone gets agitated, zero training in what to do if they demand to go home and want to go outside and walk in the street. And we're expecting these low-level, in a sense, medical professionals to be able to manage something that is very difficult and can be very overwhelming. And so I think one of the keys is for us to advocate for people like our CNAs, our nursing assistants, our home health aides, to be able to get very specific education in brain injury so that we know what to do on the front end and we don't wind up over-medicating this group of vulnerable people. So if you liked what I said tonight, please let me know. It is the most important thing to me that I'm spending my time doing this, because it is truly getting to the people that need to hear it. I truly believe that knowledge is power, and that there's comfort when we know how to understand a behavior, or when we have a good explanation for what's going on. So if you feel like these talks, this one in particular, has lightened your load in any way, if you have an experience that you were reminded of by anything I said, please share it with me here. It really, really makes a difference. So I will be back next week, Wednesday at 6 o'clock, and I'm actually going to talk about the impact of chronic stress on us, our brain functioning, our mood, our memory. I have had some pretty stressful things happening in the last few weeks, and boy, was I reminded of what it can do to you emotionally, psychologically, in terms of your sleep. But there really are coping skills that, when we remember to use them on a consistent basis, can really take us through without taking such a toll. So that's what we're going to talk about next time. Thank you guys so much for being here with me, and I hope you have a great rest of your day. Take care. Bye-bye.